What about the healthcare personnel you have? Do you have the resources you need, or do you think that you'll run short on them as well? Do you see infected cases in your hospital?
So we do see infected cases at our hospital. When we started off, every patient that was even being suspected to have coronavirus was being placed in airborne precautions in a negative pressure room with a PAPR or a face shield with an N95. The CDC changed their guidelines about a month or a month and a half ago to where we can start using a surgical mask with a gown and goggles or a face shield. And so that's made healthcare resources be a little more available for everyone. But we're going to run short. If this doesn't end soon, no healthcare system is prepared for this kind of a burden to their system.
Maybe you can also comment on the question whether or not you see a problem within the healthcare community population. A lot of cases among doctors and nurses. Do you see, of course, your staff being affected?
What we know from China, it was published, the risk of contamination of healthcare providers in wards, emergency wards, infectious disease wards is high. In China, in Wuhan, during the first month, 38% of healthcare providers in these hospital wards were contaminated. And there was also a high rate of non-COVID patients contaminated. In the ICU, it is much less. In Wuhan, the contamination of ICU health care providers was around 5%. In our ICU, we do not have yet one contaminated doctor or a nurse. Why? Because in the ICU, we are used to protect ourselves, and the protection is total. So it makes a part of the difficulty, because to enter a room and to go outside takes time, because you have to wear and unwear a suit, sterile suit, gloves, wash the hand, put a helmet with, But again, the contamination of a physician in the ICUs is very low. So the risk is in hospital wards. And then they worsen, and then they go to the ICU.
Yeah. I mean, one topic which has been very much on the mind of doctors, especially in Austria, because I've been following along the social media here, is should we test all doctors? Is that something we should do? Because, as we discussed earlier, we are a risk group.
Right, and one of the things that concerns me is it could be two-faced. It could be great in a way that, you test the hospital, 30% of your staff is positive, right? And so you get all of those staff members out of their workplace, and now you've got your 70% of your force of healthcare workers that's taking care of 200% of a patient load. And so unless healthcare workers have symptoms, I personally don't think we should start testing everyone. It's counterintuitive in some aspects, because you could be someone who's contaminated and you could contaminate other healthcare workers. When we see patients, we're taking all precautions, and that should not permit any transmission of infection from doctors to patients. But the healthcare workers absolutely are at risk.
Yeah, it's certainly a very controversial topic, because we as doctors definitely want to know if we're at risk or not. And when I was talking to some of the colleagues from Italy in the previous webinar we held, where we had some Italian colleagues with us, they said, well, as a matter of fact, they don't test us anymore because so what? We're probably all infected anyway. Only if they really become symptomatic with progressive symptoms, not even mild symptoms, would they be tested. But then again, of course, my thoughts are, well, you know, you've got these people running around. They go home, they go to work, they meet other people, they work within their doctors, colleagues. So this is, of course, a threat that I see, because definitely, you know, we'd, of course, spread the infection to the whole medical community. And after all, we're their caregivers. So this is something that, you know, it probably is a little bit of risk. But again, it's a very controversial topic, and I agree, especially given the fact that we do not know exactly how high the sensitivity and specificity of the test really is. Yeah.
And one of the, it's interesting because my wife is a pediatric cardiologist. She works at a children's hospital, and I work in an adult hospital. And so I come home from my ICU, which I may have had contact with patients who have COVID. I'm going to give it to her, and then she gives it to the kids that she's taking care of. Obviously, we know that kids are not as bad as risk, but if we infect enough kids, I guess we'll find out, and that's scary.
Yeah, absolutely. I mean, it's this chain which is so, you know, sometimes difficult to see, especially when, again, coming back to some of the colleagues in Italy, and I was discussing the question of why they have such a high mortality. And I think it's also the way the Italians are organized in their social culture. It's they closed the kindergartens down, and they went straight to the grandparents, and that's who would the caregivers for the ones who took care of the kids. So obviously the infection spreads via these channels, and sometimes we have to be aware that there's a lot of traces we're leaving in the dark without even knowing who we're infecting. So in essence, I think it does play an important role to know who the people are who are, of course, infected. But let me now move on, and I would like to just simply present China, because we have very strong ties to China over many routes. From our platform, we have a lot of people who are users of our educational content, and through our hospital, we have a lot of Chinese nurses. And we have, of course, Dr. Hong, who gave me a lot of information here, and I was discussing you know, this for the last 3 or 4 days, and she was giving me a lot of insights, together with Dr. Wang, who is in Shanghai now. And I think what is so important, and this is maybe very similar to what Martin presented in his lecture on South Korea, we can really learn from them and see how they mastered actually this crisis. And this is a very short video where I'd like to present to you, which Dr. Wang made, just to show how they cope with the situation now that the virus has, I would not say defeated, but at least, you know, pushed back, because definitely they're afraid that there's going to be a second wave coming. And this is how they protect themselves from the second wave.
Okay, now let's follow me. Here is the office. When you try to use in the elevator pushing the buttons, you need a pen. The elevator has been cleaned 3 times a day. There is disinfectant outside the elevator. Using keys to open and close the door. Packages and mails used to put here. Now we change places. Pregnant women using the special pathways. We have 7 big entrances like this, but nowadays only 1 for patients to come in and go out, 2 for staffs. Here is the outpatient department. Patient needs to make an appointment to come into hospital. And there is a temporary tent for the temperature testing, and the patient will report their history. Here is the emergency room. We're also checking their temperature. There is a special building for the passengers from Hongqiao Airport. When they have suspect symptoms, they're going to quarantine here. Fever clinic is here. It's totally isolated from the other ward and other clinic. When patients have the fever or suspect to have coronavirus disease, they're sent here. Patient family needs doctor's permission to come to the inpatient department. Now we put the packages and mails in that house. I usually could go out and get through this entrance, but today I could only go in from this entrance and couldn't go out through this. Surgeons working in this building, when the disease spread, we only do emergency surgeries, but nowadays it came to normal. Because the proper rate protect, we don't have doctors get infected of the coronavirus disease in our hospital. And we have faith in conquering all this. I wish you all good luck.
Yeah, well, I guess we can definitely need all the luck, and I can only congratulate China with initiatives of course, fighting the battle, and at the moment at least being on top of the virus. As Jean-Jacques mentioned, I was told they brought in 25 to 30,000 nurses just to fight the battle from different regions. So it was almost like a new army moving in. Jean-Jacques, maybe let me ask you, is this something, or the precautions they're doing there, is that something very similar to the way that you're trying to prevent more cases from coming?
It's too late, I guess. In east of France and Ile-de-France, it's too late because the number of contaminated patients is very high. No, 300,000 people with symptoms that were found contaminated. So probably the total number of people contaminated is threefold. It's not the case in other regions of France. In fact, we have clusters. East of France, Ile-de-France, like we have cluster in United States. New York, California, Washington. So maybe the way to control the outbreak when it is starting in some part of the country is different. Maybe we should use the Korean way to do it. And in regions with a large number of contaminated people, the only way is to shut down and keep a minimum of economic activity with facilities for healthcare providers.
So this is definitely something which is important. But the other thing which is very important as well is the protective clothing. And this has been a big issue. You've mentioned already that there's a shortage of personal protective equipment, that we're hoping to get more of that equipment soon. But it's very important also that you know how to wear this equipment. And there's now a lot of initiatives that are trying to teach people, once the equipment is here, how to really use it. I will show you a video, which is an official video from China that demonstrates just in principle how it should be done. This is just a short version of the video, but I think it also gives you a little bit of a feeling of how strictly these things are organized in China.
穿防护用品应遵循的程序：7步洗手。戴医用防护口罩。穿防护服，一定确保拉链前面胶带严密。
So this basically is just an example of how these programs are used to train the people to put their clothing on, and even more important, to take it off. We from One to Sonography are now working on a project as well where we are going to film and provide a tutorial, a video tutorial for everyone who is involved to learn more about the hygienic aspects of it. So we're working hard, hoping to finish production within the next week, and so that we can give this lecture to all of those who are involved. I think it's a very important aspect of protecting ourselves that I think is also on the forefront of our intentions. And just to show you another video, it's also very important to get a bit of a feeling of how the situation there is. And this is now a video demonstrating just the environment that the people are working in.
我们吉林省支援湖北首批医疗队他们工作的区域。截止到今天我们这支医疗队呢已经来到了湖北整整60天。我们的医生们呢在这里 一共接诊了109名新冠肺炎的患者，其中呢有一个好消息，就治愈了100例。
我省支援武汉首批重症救治医疗队是由呼吸科、感染科、感控科、重症医学科等相关专业的137名医护人员组成。1月28日起，在同济医院中法新城院区 C12层东区接诊新冠肺炎患者。
稍后疗区仅有的3名患者呢，将被调配到综合内科，也是其他的科室进行进一步的治疗相应的基础疾病。那么
So basically what you're seeing here is you're seeing the so-called half sterile room, because you have to imagine that it's also important to build a pathway into the area where the patients actually are. So you have to have, of course, a lot of, I would say, logistics in place. So yes, you will have a region, and this is the region that you can see here marked in yellow, which is completely clean and sterile. This is where the patients would go. And then you have a halfway infected place. For example, if you go in and you want to dress, you need to have these different step approaches. This is how China is working, and this is a map which actually came from a Chinese hospital, which is now translated so that I can understand it. But it's important that there's more to hygienics than just the clothing. It's also how actually to do it. And the third part is the clothing itself, to have a protective equipment. And here we have logistic problems at the moment in many parts of the world. As a matter of fact, a lot of the equipment that is needed is now being produced and being provided. And we in Austria are in a, I would say, relatively difficult situation as well. Unfortunately, we had good ties with China, and when the situation was really, really bad in China, we brought equipment to China, and China is now helping us and bringing us some equipment back. And this is an airplane. You can see it's an Austrian airline plane where we have packages of equipment which is now being flown into Austria so that we can satisfy at least partially the needs of the hospitals. But one problem, and that is something that I see among our colleagues, is that doctors are very strongly affected. This is a study which is actually not a study, it's more statistical analysis, which was performed by Curicchio in Germany, which has a very similar situation also. And if you look at the numbers here, we see that a significant part of healthcare institutions, private clinics, but government-based clinics, so outpatient institutions and hospitals are already involved, and that we have a lot of cases among the community of doctors and nurses as well. In my hospital, in the Medical University of Vienna, we also have cases. Yes, we've seen them. And this does present a difficulty. Basically, what we try to do is we try to form teams A and B so that we can be sure that there's a replacement of cases. So I think that's just very, very important. So, of course, this is very, very important at the moment to also perform statistics, not only based on, I would think, science, but also perform surveys as the one that was just done by Curicchio, who we're very happy to partner together with. Finally, I do want to come to an issue and then kind of move on to the next topic, which is going to be basically ultrasound, and that is just a video that it's been circulating in the US and also on social media. And maybe after that, I'll have you comment on your thoughts on this.
All the patients in this room, all the feet that you see, they all have COVID.
The frustrating thing, all of the doctors, it's hard for us to get tested even if we want to, even if we have symptoms. We're exposed over and over again. We don't have the protective equipment that we should have. So we were seeing a lot of patients who probably had COVID, but we didn't realize. 10 residents and also many of our nurses and a few of the attending physicians got sick. The anxiety of this situation is really overwhelming.
So this is, of course, from the US, and I would like to maybe again ask Balil what your thoughts on this, especially with respect to one problem which I see a major problem, is that we still have patients coming in for other diseases, and it's sometimes very difficult to say whether or not someone of these patients has the virus. And what about a patient with dyspnea, for example? Would we put everyone through a test? Should we perform a CT in every patient? What is your take on this?
So for most patients who are coming in who don't have a fever and don't have specific symptoms that would be suspected for COVID, if they're short of breath and they have pulmonary edema on a chest X-ray, their BNP is elevated, we know they have a history of heart failure, their legs are swollen. Those are people that we're considering low risk for COVID-19. And if we have an alternate diagnosis that explains their sickness, those people do not get tested. Only patients who have no other explanation, and we think this is a infectious syndrome, and that can be from a lobar pneumonia all the way to flu or COVID-19. All of those people get tested. If you're getting admitted to the hospital for a respiratory illness, regardless of whether we think it's an infection or not, that will get you tested as well. The problem now we're running into is the sensitivity and specificity of these tests. And so a lot of patients are actually getting double tested. So they'll get a first test done, and if we feel that their risk is really high, we'll retest them at 48 hours. And only if they have 2 negative tests do we take them out of precautions. If you have 1 negative test, but we also have an explanation as to saying that you have strep pneumo antigen positive on your urine, you're getting better with treating your pneumonia, and your COVID-19 test is negative, those are people we're not retesting.
We get some questions about disinfection from Ursula. She wants to know, how do you disinfect actually probes, and what kind of what substance do you use for the instrumentation, for example, also for the point of care ultrasound device?
Yes, very easy. You use your common hydroalcoholic solution, and then you just clean all the surface. So it is very difficult for bulky ultrasound devices, because you cannot clean all the surface. It's very easy with a pocket-sized ultrasound device, and you can repeat as many times as you want the ultrasound examination on the same patient, on a different patient.
Very last question is related to the question of what kind of masks are there and what should we be using? Any comments maybe from the panel?
So in the United States, we're using N95s or PAPRs. We have these PAPRs that are almost like helmets that have a face shield and a respirator on them. Those are pretty much reserved for any patient who's at risk for aerosolizing their secretions. So people who are intubated, getting CPR, nebulizer treatments, either on high flow nasal cannula or a very rare instance using non-invasive ventilation. But all the other patients, even if you're being tested for COVID-19 at this point, you would get N95 and a PAPR. But if you are not diagnosed, if you are just being tested right now, you would only be in a surgical mask and a gown until your test comes back negative. And that's in part a measure from data, but also to try to conserve the supplies we have.